Hello, I'm Howard Hu. I'm the chair of the Department of Population and Public Health Sciences here at the Keck School of Medicine at USC. Welcome to today's very special occasion, which has the double honor of being one of our department's grand rounds, as well as the Dean of Medicine's inaugural Transformative lecture series. In addition, given the subject matter and our very special guest, we have the distinct privilege of being joined by our university's president and Senior Vice President for Health Affairs to provide welcoming remarks and introductions. Please join me in welcoming President Carol Folt.
Thank you, Howard. Thank you, everybody. I know there are a lot of you online, so hello to everybody. It is so wonderful to be here, to be able to welcome Dr. Victor Dzau here to give this amazing topic. And it's true, when I first heard about this talk, I think I called him and said, I want to be able to come and do a little bit of an introduction because I'm just so excited about our amazing guest. And I know you'll hear more, and many of you know what he's done and what he's continuing to do for our country and for advancing the fields that we all study. But I think this is really important at this moment for this university too, because here we are, we're really looking forward, we're pulling together in these areas of sustainability. And at the start, our sustainability efforts were largely focused on the UPC campus, yet that is not where we're stopping. We are so determined with the leadership coming right here to really extend that to decarbonizing the health system that it couldn't be a better time. Yesterday, we actually announced the creation of a new sustainability hub for our students. And just a little bit of story, it's going to be a place where they can all come together on the UPC campus. But trust me, we want to get something like that over here too. But there's a wonderful symmetry to it. And I think Dr. Dzau will like this. When I was in my inauguration, there was a protest at my inauguration. Now, we were both in North Carolina, so he knows all about protests in North Carolina. But that protest was our students protesting about climate change. And I was invited to that protest. So I went to my first protest. It was at Tommy Trojan, and we just opened the Sustainability Hub as close to Tommy Trojan as we possibly could. So there's a wonderful symmetry there. But it also talks about the fact that it isn't just us, it is this generation is determined to see us come good on our promises about sustainability. So that's why you're all here today. It's a huge priority for us. We came up with the title with our students and the President's Working Group of our big assignment as a university is Assignment Earth. And that isn't a small task to take on. So you're going to hear a lot about it, but it's going to get a big jump start with the talk today and all the conversations that are going to take place. And some things we'll do very fast. We were able to change our carbon neutrality aspirations from something like 2040 to 2025 this year. It's 2025 in part because we got a big boost. We're able to buy green energy from the city. We also have zero waste 2028. We're trying to up each of those, wanting to get to a measure of what we might call zero water. That's not easy in Southern California. So these are all areas of great interest to us. Want to increase the curriculum, really increase the research and all the service that goes along with it. But the really unique piece is that we want to do it across all of our schools, all of our professions, all the way out to the decarbonizing of medicine. So it's being driven by a lot of people. I'm just going to mention a couple here. In particular, I want to call out Howard, you, and Rob McConnell, who have been really working on that task force to make sure that from the start, these efforts of sustainability would be really important and focused on here on the health sciences. And we know, I think the calculations I was given, it might have been in the paper that you recently wrote, that something like 8 to 10% of carbon emissions in the United States right now come right out of healthcare industry. So you're not going to get reduced carbon emissions if you're not addressing this in our medical systems. We need energy and materials that can help us care for our patients. We need different ways of seeing them where they need to be seen. All the things that we're trying to do to improve the health of our populations and our people have energy and sustainability implications. So we need to be thinking about them together. And that's what I think you're hearing about today. They are going to have a real push as we move forward, in part because there's such a big effort here that is already going. And it isn't just students, it's not just faculty and staff and students at Keck and the allied health schools. We've also got a lot of partners right in Viterbi too, who are here being a part of this whole push forward. So that's bringing in a lot of additional faculty with great interest. Then you bring in Dornsife, then you bring in the art schools, and pretty soon we're doing what the university wants to do, is to work together on one of the most important issues facing the planet. So it's exciting to be here, to see you all here. And I want to just take a moment before I turn it back to Steve, just to reiterate what Dr. Dzau has done himself. And of course, you already know, most of the people here, I imagine, or you've crossed paths, but this is a group with very open minds to this subject. 10 years ago, it wasn't true that people were that open to it. I attended the first climate change seminar in Washington in 1994. And in America, it was about the first time. And I spent more time in the next 5 or 6 years just trying to talk to my own colleagues about whether climate change was real. That's not true anymore. Everybody understands it. They are fully embracing it, and it is spreading in ways that are new, but it needs leadership at the top national level for it to really be effective. And that is absolutely what you've been bringing to this. In 2021, he personally led the launch of the National Academy of Medicine's Action Collaborative to Decarbonize U.S. healthcare. There's no group, no statement more important than that one, that this is what we as scientists, as leaders in higher ed and in discovery and research believe is really necessary. So when you take that on, you bring many more people to the table. So it's something to be really proud of, and we want to do everything to be a partner with you to do that. And, Dr. Hughes doing that. Steve has been very excited to have Keck join the Practice Green Health, which I think you all know is a national collaborative of more than 1,000 hospitals working toward a sustainability goal. Anytime I hear 1,000 anything working together these days, I'm feeling pretty excited. That's a really good example that when the goal is right, you can bring a lot of people together. And I think that's what we're seeing. And our own faculty, led by Dr. McConnell, have initiated a research project to do in collaboration with Practice Green Health. So I think you're going to hear more and more about it. We're going to see great things happening. We've got a lot of people in Southern California that want to see us take a lead to help our region also deal with these issues. And one of the things I've heard Mayor Garcetti say is that we know the world is becoming increasingly urbanized. And if you can't get things right in your cities, you will never get things right for your planet. And this is a place where we're trying to do it here, get it right for our city, get it right for our nation, and maybe we really can get this planet back on track. So thank you. It's great to be here. And thank you, Dr. Dzau, for being here. Thank you, Howard.
Thank you, President Folt. It's great to have you here. I know that this topic is really important to you, and meeting our speaker, Victor Dzau, is very important to you. And so welcome both to the Population Health Sciences Grand Rounds and, ironically, the inaugural Dean's Transformational Series. It's ironic because the Dean actually is a board member of the Radiology Association and can't be with us today, but maybe like millions of others in our hybrid workforce these days, she's listening online. But we took advantage of Dr. Dzau's precious time to come to the West Coast, and we couldn't be more pleased to have you here today. A simple introduction really can't do justice to your amazing journey, but I think it's important, particularly for the junior faculty, to hear some of it. You began the journey coming from Hong Kong to McGill for your undergrad and medical school career. Then you entered the Harvard system and actually trained as a junior faculty and mid-level faculty member at all the important places that are now Mass Brigham today, where you really distinguish yourself as a physician scientist, studying the biology of ACE inhibitors, which today is now the most common and effective drugs that we use for both hypertension and heart failure. And also was a pioneer in gene therapy for vascular disease and continued active in the lab throughout his leadership career. Victor does have familiarity with the West Coast. He went to Stanford, first to be the division chief for cardiology and the chair of the Department of Medicine, and then was lured back to Brigham and Women's Hospital at Harvard to be the Hersey Professor of Theory and Practice of Medicine and the chair of the Department of Medicine at Harvard Medical School. And had a great career there, and then was lured to Duke to be the chancellor for health affairs of Duke and the president and CEO of the Duke Health System. He spent 2 terms doing that, then went to the Institute of Medicine to be the president and led the transformation to the National Academy of Medicine, where he's the inaugural president of the National Academy of Medicine, and has really spearheaded so many important initiatives focusing on the most important topics of healthcare today and driving us all toward realizing these goals, stemming from global health to physician wellness and today's topic, which is sustainability. The dirty little secret is healthcare really has a pretty large carbon footprint, and we really need to get in control of it. No, what's not on Dr. Dzau's CV is just what a wonderful person and great mentor and role model he is. And I say that for personal experience, as he recruited me to Brigham and Women's Hospital in my first leadership position and really taught me through his example and mentorship to be a leader. And I'm forever grateful for that, but enough about me. Let's get to the topic. After Dr. Dzau talks, we're going to bring in 3 panelists to comment. Rob McConnell from the Department of Population and Public Health Sciences at KSOM, Bhavna Sharma from USC School of Architecture, and Najmuddin Mishkati from Viterbi School of Engineering. But first, please join me in welcoming Dr. Dzau. Thank you.
Thank you, Steve, for those very warm and welcoming remarks. And President Carroll, thank you very much for really inspiring, I believe, not only this university, but the nation in your leadership in attacking this very important issue. So when I hear about this initiative in this university, I was really excited because sustainability is such an important issue for the nation and globally. And we do know that we're able to do something about this, particularly with leadership of this university, can truly be transformative. Transformative for the young population generation, transformative for the university, and transform the nation, and certainly globally. This morning, I had the chance of meeting with a number of actually the panelists and I was working on the president's task force, like this working group, and I was truly impressed. I mean, your goals and your ambition of reaching decarbonization, net zero, and through all the work that you can imagine, education, research, practice, and now, of course, the health system, it's one of a kind. I spent time yesterday at Stanford, and of course, everyone knows about that $1 billion new school and theme, but nothing like what you're trying to do, which is a system-level engagement for the entire university and everyone involved. So congratulations, and truly an opportunity for me to come and speak to all of you. So my goal is actually simpler than this whole big issue because I'm to speak to the health side of things. And what I'm going to do is to make the case why this is so important for us in the biomedical sciences to take this very seriously and take leadership. And then tell you what we're trying to do at the Academy as a kind of effort to create, if you will, a movement so that more than USC and more than Kaiser, but others will all actually work together so that we can achieve the goals together. So, you know, when I think about what people characterize as climate change and impact, I think about the image of a polar bear on the slab of ice, and guess what? It's going to disappear soon. I think about people, you know, you worry about the planet for future generations. This slide tells you it's happening right now. The faces of climate change are human beings who are being affected by climate change, both in terms of well-being, the social environment, but importantly, the health. And I want to make this case to you that it's so important that we have to take this very seriously and we have to start acting. Now, Andy Haynes and Chris Eby wrote this paper in the Journal of Medicine, which I think summarizes the impact of climate on human health. On the top, you can see rising levels of carbon dioxide, climate pollutants, resulting in rising temperature, extreme weather events, and rising sea levels, and many others. And these events, of course, impact locally, nationally, and globally. And it's the magnitude impact is dependent on the demographic, socioeconomic, environmental, and other factors. And we'll come back and talk about that. For example, the inequities you see in poor countries, under-resourced communities, etc. But what you see in the lower part of the slide is the pathways of this climate change, which affects air quality, water quality, heat stress, food supply, vector distribution, and others. And so consequently, what you see at the very bottom is the health consequences impact of climate change. That leads from cardiovascular disease, heat-related illnesses, air pollution, respiratory illnesses, and infectious disease with vector-borne diseases, which we'll talk briefly about the fact that vectors are now moving more north because of warmer climate in north, and therefore bringing dengue, Zika, West Nile, and others, as well as malnutrition, diarrhea disease, forced migration, and of course, mental health effects, which are really very substantial. So I would say it's very clear to say climate change is a public health crisis. If you have not looked at this number, you'll be amazed as I begin to know this area better. I'm not a climate person, but certainly last few years, I've learned so much from it, and I'm learning from all of you, that, if you look at there, 20 million deaths a year that's related to key factors linked to climate change. Counts for about 50% premature deaths, as you saw earlier. And of course, the range is air pollution, but also diet, nutrition, vector-borne diseases, water and food supply, and of course, many other factors. The numbers are quite staggering when you look at this. I mentioned vector-borne disease, that in fact there's more malaria and dengue fever because mosquitoes are moving more north. But even if you think about COVID-19, many of the reasons, at least we believe, for COVID-19 were the result of factors that lead to deforestation, urbanization, zoonosis, and therefore climate change as well. So I think we shouldn't underestimate all the things that's happening in our environment and climate that can actually change air pollution, vector-borne disease, and many others. I show here that about 500,000 children die a year because of no access to clean drinking water. And of course, malnutrition is a big issue. And we all know that large population of young people in many parts of the world are growing up with stunting, with impaired mental development. And importantly, of course, there are climate-fueled disasters. And we know all about, certainly in California, and forced migration to the point there will be a huge number accumulated by 2030. We're not spared in the United States, where we are a major emitter. We're also seeing the consequences of climate change. This map from the Medical Society Consortium shows that if you map all these climate health events, it's everywhere. As you can see in the more recent report, that economic toll is huge, about 820 billion with a B annually that's being affected due to climate change. Now, we all know, as I said earlier, that impact is not distributed evenly. If you look at the slide, I would ask you to look at the upper right and the lower left. Older adults and younger children are more affected than, say, people in the middle age, etc. Older adults, extreme weather, heat strokes, you name it, the inability to being mobile, for example, with Katrina hurricanes unit, are greatly affected also by power outages, et cetera. And the younger population, believe it or not, are much high risk of heat stroke and other illnesses. But also we have to remember that socioeconomic factors matter a lot because communities of color, people who live in risk-prone areas that I'll talk about later, are exposed to multiple toxins and pollutants. And of course, low-income families with severe physical and mental illnesses and living in crowded conditions. So there's a real issue of equity also, in fact, as we relate to climate change. So here's some real data to look at environmental injustice. That is, poor communities are a lot more exposed to this climate impact than others. I just gave you a list of examples for those of you who know well about Katrina and about Flint, Michigan, but also about Asthma Alley in South Bronx, in a neighborhood of Mott Haven, where 97% living there are people of color. They actually live close to the Fresh Direct warehouse, where thousands of trucks every day come to warehouse and of course pollute the environment. Also, they close to the Wall Street Journal printing process and many other sewage works as well. So consequently, these individuals are exposed much higher to this pollution and across have out of proportion asthma in this population. Let's take black snow in Pahokee in Florida, where in fact there's a standard practice of, harvesting in sugarcane, where the practice burns the sugar fields before harvest. And this creates what is known like a black snow phenomenon that can lead to respiratory illnesses. And then finally, the Cancer Alley in Louisiana, from Baton Rouge to New Orleans, along the Mississippi River. That area has such concentration of petrochemical facilities that, of course, toxic air pollution and a lot more cancer in this area. These are only some examples. Now, why does it matter to us? Well, we are the health professions. We are the biomedical scientists. We are, of course, in this, I met a lot of people from other sciences that's working in overlapping areas, environment, et cetera. But it matters to us because as we think about health, we are responsible for climate for health. When you have extreme weather events, when you have really tremendous negative health impact by climate, we have to be the resource and the places for caring for these individuals. And certainly, I think that many of you know that facilities are greatly stressed and that we need to find ways to, in fact, care better for the patients and being prevent this. But I think something that's less well known to all of us until I really dig into this information is that we actually a major contributor to climate change. When you look at the healthcare footprint, 20% of GDP, that's huge. But surprisingly, we emit about 8.5 to 10% of carbon emission in the United States. That's one of the largest industries you can imagine. It's even higher than cement industry in terms of contribution to carbon emission. Many of you know this well. When you look at the sources of emissions, we divide them in scope 1, 2, and 3, and we probably will talk a little bit about this and what we can do for each scope. One is what we do in the operations of facility and the way we care for patients. There's a lot of opportunities for us to make a difference. Because after all, we only want to provide better care to our patients. And so why not change the way we practice? Second is we're great purchasers of energy, heating, cooling, as you all imagine. And of course, already starting here in USC and in NHS in England and other organizations, we have to begin to look at, as you heard, what's our building, LEED certified, what kind of energy do we use, et cetera. We can control those things. Third is a much larger issue of supply chain. That is, in fact, health services and goods, which are more indirect, But nevertheless, they are huge. They actually account for about 70% of overall carbon emissions. So we need to talk about that as well. So when you look at overall, the US health sector, 8.5%, but if you look at contributed globally, it's like 25% of global health sector. So you can imagine we're proud of what we do with MRI, with surgery, you name it, but we're also the leading country in terms of carbon emission. Now, I think, and the main reason I want to talk to all of you, and maybe many of you are converted, but I'll bet you many clinicians and others who are busy with their work are saying, why do I need to worry about this? My job is to take care of our patients. But as you know, we took a Hippocratic oath to say, do no harm. When you consider the damages from our healthcare industry ourselves, the amount of pollution estimated to the same order of magnitude from deaths from preventable medical errors. Remember, over 20 years ago, the IOM and now the NAM wrote this report, the air is human, and a series of reports about, preventable errors. This was big time. I think our report 20 years ago says 98,000 people dying from medical errors. If you imagine, and today, of course, the numbers are higher because of more complexity and older population, despite all the work that's been done in 20 years. But if you imagine this is the same order that we now do with US healthcare pollution, that's really quite amazing. And of course, the disproportionate impact on people of color, marginalized and disadvantaged population. So I think it's not only to look at our share of the burden, that is, we should do no harm and reduce carbon emission, but also I'm going to make the case in doing so, we're actually going to improve the health of population, not only by reducing carbon emission and all the air pollutants, but also actually it's better for patient care. So I just want to say to all of you, as healthcare professionals, as biomedical scientists, as university leaders, still we are the most trusted voice in by survey. And we have an obligation not only to act, but also to communicate to our patients and to our public, and also, of course, to each other to practice what's best for our patients. So what do we need? Well, there's no question when I start looking at this issue that there's no organized effort to address this issue. And what we really need is bold approaches and transformative ideas. And importantly, cross-sectoral partnership. I'm so glad to see our engineering folks here, folks from the undergraduate campus and architect all coming together to say, how do we make a difference here? But we need, as we discussed earlier, a lot more investment in this area. Can't just happen out of nowhere. And of course, that means that we have to change funding approaches, funding agencies, to look at this issue as really important. The amount of research, investment, funding, at least by public NIH and others, is very small, if at all, compared to disease orientation, Alzheimer's, cancer, you name it. So we have to begin changes in this area altogether. So this is where we came in. First, I have to give credit to many of my members. Many of my members, Charlie Halpern, Dick Johnson, and Gary Cohen and others says, you guys got to do something about this. And of course, as we think about ourselves and uniquely our platform, we do have a unique platform to do something. And that's what energizes us to do this together. So the founding academy is the National Academy of Sciences in 1863. This is chartered by Abraham Lincoln Congress to form an independent academy to advise during Civil War the government on issues of science and other decisions. This is very wise. We're not part of the government, and yet through 160 some years, we have worked so much with government. We do have a lot of influence, and frequently Congress or the agency will ask us to do a study to help them make decisions. But others, sometimes we would just simply take our own initiative to ask those questions to be informing the government and the nation and the public on important issues. So to a large extent, for NAM, we set the agenda for health and medicine. And of course, we have phenomenal members. Some are in this room today. They bring with them their expertise, their passion, and we bring other volunteers the best to do two major things: convene and then advise. In convening, we can bring together the best minds together to look at an issue, create reports, and of course, influence policy. And you can see, I've shown here some of three of our reports. There's human, mapping human genome, and the genome editing. And of course, I gave a little bit of advertisement at the bottom of the slide from the New York Times saying who we are and how well we do. But the key issue is that we have been working in climate for a while. And you can see there's a number of reports that talk about this, not only in the NAM side, but on NAE and NAS. All of us, we work in climate, but we have taken it as a topical issue. I think it's time that we now come together to look at it as a major strategy and mission. First, I should tell you that across the academies, we have launched a big cross-academy initiative, the first ever, called Climate Crossroads, which all three academies are working for the same purpose: bring together our members and expertise to think about how to attack some of those issues. Today, I'm going to focus more, of course, on what we do in NAM, which is part of the climate initiative, Climate Crossroads. But of course, there's a lot more than this. What we did was we spent at least 1.5 years planning, almost 2 years, bring together best minds from all different fields to say, what is it in climate and human health and equity can we do? What are the major questions? What can an organizations like the National Academy take on? Because obviously we don't have absolute bandwidth. We can't do a lot of things. But so this planning group, led by many people that you know, came with the idea that you should first embrace this as a grand challenge. This will be the second grand challenge in the NAM history. So under my leadership, we've done longevity as one, and now climate change. And the whole idea is to look at how to improve and protect human health and well-being and equity by looking at transforming systems that contribute to an impact like climate change. So what are those objectives? First, communication. As I said, I think the public are not quite aware of the gravity of the whole situation on their health. And secondly, even our professions are not quite aware of the impact of what we do on health. And so we have an obligation to communicate well, and particularly emphasizing the issue of equity. Second is what I'm here to talk about today as well, which is how do we actually walk the talk? That is, act by starting showing examples of decarbonization, not only because it's the right thing to do, well, not only because it's to walk the talk, but it's the right thing to do. Third is to look at much larger question, because when you think of climate and health, it's actually the impact of multiple systems: transportation, energy, agriculture, water, and how do we transform all those systems together? Next is looking at research innovation. The only way we're going to get there is to have much more interest in research, much more information, where to intervene, and of course, more innovation. And finally, look at and not the least, looking at inequities. So I think the Grand Challenge is really unique because, as you know, you think about the academy, we bring together bright people, scientists, academicians, healthcare workers. But this one, we actually did what we call radical partnership. Everybody who's a stakeholder is at the table of bringing public and private together, because we can't just simply talk about this. We need everybody to act together. So this whole partnership is chaired by Judy Rodin, who was the former president of Rockefeller and former president of the University of Pennsylvania, and Sir actually now by herself, but previously with Phil Pizzo as well from Stanford. We have, as I said, multiple experts, diverse sectors to look at what are the issues that we need to address in the grand challenge. It's a private-public collaboration. So we partner with HHS and the US government. In fact, Rachel Levine, I'll show you later, co-chairs with me on the decarbonization effort of the NAM. We partnered with CEOs and leaders of industry, biopharma, device supply chain. We engage global academies, we engage healthcare systems and all this in order to advance the changes that's needed in health and climate. The way we approach our work is divided into these pillars: communication, decarbonization, system transformation, research innovation, and of course, equity, cross-cutting all those different pillars. So let me speak briefly about each one of those. First, communication. One important area we recognize is, as you see in the bottom and the last two bullets, is to go to public. And we are not a huge organization, so we have to collaborate. First of all, within the national academies, we have a climate communication initiative. And now we are working focus on the health aspects of it as well. But we also collaborate with global organizations which are in the space because of the use of social media, the use of television, and many other mechanisms. But I think the top one is important because the messengers, everyone healthcare worker can be a great messenger, so that if they are communicating with their patients, with the public, and as you're doing with the students and learning this area, that's critically important. So that's one of our major areas of work. Second, as I mentioned, is look at systems. When you consider that, there's so many systems intersecting with each other that leads to the change in climate and directly or indirectly on health, such as food systems, transportation, etc. We want to do a report that look at the macroeconomics of all these systems and how do we transform this all together. This will be led by Judy Roden and Sir Andrew Haynes from the United Kingdom. Third is research innovation. We talked about earlier in the small group that I met with about the fact that currently it's very fragmented and really modest funding. And in fact, it's insufficient funding looking at the health consequences and health equity. And so we believe we need a lot more investment and a lot more evidence. And of course, in the global arena, to look at bridge between low and high income countries. And of course, data sharing, collecting data and being able to use data as knowledge to set a global agenda. So I won't go through the areas except to say what we've landed is, as we have done so, with bringing together funding agencies, NIH, NSF, Wellcome Trust, Rockefeller, Gates Foundation, and others. We've convened several meetings to say we have to think about beyond the way we fund research to create a larger footprint, crossing different disciplines and being able to fund interdisciplinary work. So that's one area. The second area I believe strongly is to look at the healthcare delivery system. How can we incentivize healthcare delivery systems, hospitals and others, to provide them with research dollars to look at what kind of things can we do to improve them? As a corollary of that, we have seen the patient safety and quality movement and the whole area of innovation at USC and many others at Duke, when we empower the professionals, the workers to say, I've got a good idea. I want to be able to get some seed money to do changes. At Duke, we have a system whereby we have application every year. We give them seed dollars for good ideas, but selection usually, how does it improve patient care, and how is it actually related to strategic direction health system? So usually there will be an innovator and an executive sponsor. And then we move forward with some of the changes. And then, of course, finally, we need a lot of innovation, looking at packaging, supply chain, you name it. Also, as you are engaging in your community, we believe there's got to be a national effort in engaging vulnerable communities in this effort. So bring together lived experience, NGOs in the communities that's working on the issue of sustainability and climate, and being able to represent their voices, to talk to each other, to inform decisions. And along with this communities network globally, we're going to bring in EPA and HHS and others to have dialogues with, in fact, the community and allow the community to be aware of what are the opportunities for them to access resources and to learn from each other in terms of best practices. And okay, so what I'm now going to focus on is the decarbonization aspect. We have decided to do so, you need all stakeholders at the table. That's why we call this a collaborative. That is, all the coalition willing are working together to act together, to collectively make decisions and to move forward. So one of the big collaborative goal is to bring all the healthcare sector together. Supply chain, healthcare delivery, education, communication, policy, finance, as well as metrics. And so this collaborative has health systems, clinicians, private payers, biopharmaceutical, medical device, education, academia, and the federal government as well. So the structure that we have is a steering committee of the major leaders in this field, and we divide into, in fact, 4 working groups: supply chain, healthcare delivery, education, and then policy and final metrics. And the way that we've organized this is that we have core membership that work on these working groups, work streams that inform the steering committee in decision going forward. Then we have a large network organization that just simply get resources from the collaborator. And I think it's important to point out this is truly a public-private partnership because co-chairing with me is Admiral Rachel Levine. She's in charge of, at HHS, Assistant Secretary of Climate, the Office of Climate, Health, and Equity. Also, Andrew Whitty co-chairs with me. He's the CEO of United and Optum Healthcare, the largest database, the largest healthcare, and have tremendous information. And supply chain, former CEO of Cardinal Health, the large supply chain. So it's a true public-private partnership. But I have people like Gary Cohen that Howard knows really well, you're working with, and many others, Don Berwick, and people that you can easily see, Jonathan Perlin, and many others. But importantly, I think they all are leaders in their own field so that they can go back and have a multiplier effect by influencing Joint Commission, by looking at Liz Fowler from CMMI, Medicare Innovation, by looking at people like, again, Michelle Mary Heath on the Biotechnology Innovation Organization, David Scotton from WMC, etc. So these 4 working groups, and I'll talk a little bit about how each one of them. I want to hasten to point out to you, of course, we can't cover everything. We really are the coalition willing. But when we first this initiative, by extending to a lot of people, the amount of enthusiasm is there. You can see people really are beginning to get this. The question really is how to mobilize the entire sector. I mentioned earlier, the supply chain is a very important area. And that is probably the most difficult area to work in because these are large companies in device, in supply, in biopharmaceutical, where in fact, they are multinational companies as well. Now, many of them are members, CEOs already saying, we are doing it because we have ESG, an initiative. And so some are not, but there's already movement. But I think many of their questions has to do with what's our standards? And we vary tremendously in size and scale. How do we bring together? How do we measure them? How do we learn from each other? And how do you fit new products into, regulatory frameworks? And I'll come back and talk about that later on. So this group has already been looking at opportunities to reduce carbon footprint together. And consequently, they are looking at resources, best practices. And I'll talk to you later that in fact, they created a journey map for supply chain so everybody can see what's needed to get there. By the way, before I go into this detail, I would say the collaborative has also together agreed that we'll work towards the same, very similar goals as you have. 50% reduction by 2030 and net zero by 2050 as a collaborative. We are trying to pull together the measurements of every single member's collaborative, which has not been easy because standards of measurements and willingness to share data remains to be a challenge. But that, in fact, is our goal because we said that's what we're going to do. So in the next few years, that's a primary goal that we're going to go forward. But with each one of these groups trying to address some of these issues. So in the care delivery, for example, Scope 1, Scope 2, you're already doing a lot of that stuff. As I heard you about your today, the practice green health is really helping you measure many of these issues and you're leading them. But I think what we hear from the CEOs and others is, boy, we are really stressed. I mean, we've got COVID, we've got burnout, so many things. Is this one other thing we need to do? And is it cost us money? We're gonna, there's gonna be more pressure on us. So I think one of the things we're gonna do is make a very clear business case to show that as Kaiser and others have done, once you achieve it, you actually save money and you become more efficient, you're better for patient care. But there are not enough financial incentives for nonprofit hospitals and others. And there's a lack of shared measures as, you heard 1,400 hospitals only. That's a small percent of all the hospitals in this country. And of course, the measurements are highly variable. So we have to build a case for decarbonization, agree on sustainability, indices for measurements, look at best practices, and of course, highlight the challenges and regulatory opportunities. And in education, the whole point I've been making is that we don't train our professionals enough. So this group is looking at introduces into curriculum, the AAMC, ACGME, at least to be knowledgeable. But as I said, we need to both practice as well as communicate with our patients. So a lot of their work are looking at what do we do to improve communications here in a more systematic way. And then this group is really interesting. It's co-chaired by Liz Fowler, Jonathan Perlin, and Don Berwick. They're saying in order to make this happen, we really have to look at incentives, policy, and financing. Can't just simply say you got to do it. So how do we do this issue? So they are coordinating across all the working groups to look at some of these fundamental issues. So trying to create an integrated, cohesive policy and regulatory agenda, barriers and opportunities. Look at financing mechanism. For example, can CMMI actually provide incentives for organizations to take this on, right? Like you have an ACO and others. And Liz Fowler is talking about, can this be in fact part of value-based care and reimbursement? And of course, we need to look at the metrics that's going to be have to standardize. So we have done, as President Fault said, we launched this in September 2021, but we've been planning this for a long time. So we've only been actually moving on a little bit over a year, but we've done a lot. So first of all, the core members are 70, and I certainly welcome USC part of this. In what you do, you have so much to offer and to learn from each other. We have 60 network organizations, but now with the HHS pledge, where they have somewhere over 100 organizations, they're all going to join the network. Now, it's hard to know how many entities we've and cover it. You can measure, you can say AHA is part of this, there are 5,000 hospitals, so you got 5,000 entries. It's nice to think that way, but of course, the whole issue is that how would these associations be multiplier and bring it to their organization, to their members, to in fact standardizing strategically to imply. I think our success will be to have that kind of multiplier effect. We certainly have video series, public meetings, work with the White House to have the pledge event, and we have created a strategic framework to guide the work on engagement, metrics, policy incentives, R&I, and research equity. And I said, we have set our goals together and already heard about 5 working groups. I'm going to simply skip through these slides to enable more conversation. Suffice to say, we have priorities, we have products in every single area we're trying to move forward. But I do want to point out, for example, in the supply chain, we have created a climate journey map, a resource repository for all the supply chain. By the way, we have the largest supply chain alliance, that people who are actually truly transportation, move products from one place to the other, in addition to manufacturing and all the other stuff in the industry. And of course, you know, I mentioned that we also have carbon clinics. You can see, I think, down in one of these bullets to look at how to help people to learn how to do these things. And so sorry about skipping through this. So I think that we're going to work hard the next few years and hope many of you can join us to look at how to meet these goals and how to complete the work products, how to mobilize the sector and create a strategy that's truly transformative. The more people join this, the better. I would say the strength in what we've done in the collaborative in terms of coalition willing is that the leadership of pharma, device, hospitals are all at the table. Challenges is, of course, people are all different stages of their development and trying to standardize and move things forward. So we are moving this year and reporting those who are ready. Those who are not ready, we're going to help them get there next year. And so you stay tuned for our effort. Another issue I want to bring up is the global issue. Of course, this is US focus, but we recognize this is a major global issue. In fact, the low-income countries are the lowest emitters, but the highest, shall we say, recipients of the damage from carbon emission. Here is Pakistan, the flood in Pakistan, the drought in Africa. Right here, the wildfires in California, the famine in India, and of course, the hurricane in the Philippines. And we're working on the idea of creating collaboration where we shift from one size fits all, a top-down approach in working with local collaborators to under their specific conditions to create partnerships rather than the standard donor-recipient relationship, to build capacity, to have ownership on the ground and strengthen local capacity. And of course, doing research with evidence in science and partnerships in science and equitable partnerships, capacity building, and resource and tools. So thank you very much for listening to me. We have a big agenda going forward, as you can see. We are going to launch a roadmap this year. We are launching the communities network this coming year. We are going to continue a decarbonization plan. We're going to work with funding agencies to develop a strategy for research innovation. And of course, we need to continue to build our communication effort. And thank you very much.
We're going to enter the panel part of the event, where our 3 panelists, Professor Connell, Sharma, Mashkati, will be joining us. They're invited each to give a short response from their perspective in different disciplines in medicine, engineering, and architecture. and also to pose a question to Dr. Dzau. I also invite the audience to think of the questions they'd like to pose to Dr. Dzau. We have mics on either side of the auditorium. Once the panel part is over in about 10, 12 minutes. And those who are viewing on Zoom are invited to submit questions to the Q&A. They'll be curated and we'll try to get to those as well. First, let me ask the panel to proceed, starting with Dr. McCall.
Thanks, Howard. And thank you, Dr. Dzau. That was a really inspiring presentation. I have a couple of comments in the form of questions. One is that, around this room, there are more engineers than we usually see here at Keck. And one of the challenges that's impressed us in trying to develop this initiative is how to speak the language to communicate across these various disciplines that are so important for making progress. And in that regard, I'd be interested in the activities of the other academies. You mentioned that there are three academies. This is an unusual activity. It's not just the Academy of Medicine. And if you could tell us a little bit about that, and also, the lessons that might be available to us in working with our colleagues across the university.
Thank you, Rob. I mentioned earlier, at the very outset, that we are committed to work across the academies in a common project called Climate Crossroads. And the starting point, we do know that each academy have already activities in this area. And engineering, as I talked to Meta earlier, that she's a member of NAE, that in fact their whole annual meeting this year's theme is on energy transitions. So engineering has so much to bring to the table because they are the organization that come up with solutions, particularly when you look at, solarization, many other energy sources, and designing mitigation technology, et cetera. So already lots of opportunities. In the NAS is really in many ways a really interesting academy because they are broad in terms of scientific expertise, from economics to, in fact, chemistry, you name it. But I think where we overlap tremendously, of course, is not only in the life and health sciences, agriculture, for example, right, and environmental sciences, but also the idea of, social science, many others. So there too. So we are really together have created an executive committee and engaging, as I said earlier, with the private sector to look at what are the major areas think they want to work on. US government, for example, has already come to us to say, with all those things in terms of sustainability, decarbonization, what is the future impact on the economy of the United States? Well, that's an interesting question, right? Nobody's ever thought about, is this going to be good or bad? So that's what we do. We can do a study to look at modeling, to look at engaging the US government to make the right policy once they understand the implications of what it looks like to a country.
Barbara.
That's a great segue to my question, which is that the health sector is predicted to grow 7% in the US over the next 5 years. So how do you envision meeting that demand while also decarbonizing?
I think the real question is that if we do right and we do fast enough, we actually would be even better prepared than the 7%, because 7% is probably what, GDP, right? But in fact, you're talking about demand. I would argue that if you look at what's happened in COVID in terms of switching to telehealth, right? And that to me has been lots of lessons learned. And the willingness of the US, therefore CMS, others to say, let's relax the rule and continue to allow the practice of telehealth, and the reimbursement and even cross states. Now, imagine what's happened when you do that. One is you don't have to drive to LA to see your doctor, You understand exactly what I'm saying about, carbon emission, transportation, time wasted, right? But also, it's actually much better to care for people at home, in the community. And in fact, as you look at the practice of medicine, so much of this for us is ritual. That is, you got to come in, get this checked, and then go through all this stuff. That in fact, efficiency and better health outcome. Now, that's how you may be able to meet the demand. There'll be much less need for hospital beds or clinics. And one would imagine we do the same practice of medicine in prevention and others, there'll be less need for surgery and high energy, interventions and imaging, you name it. So I'm hopeful that's the direction we need to go by staying ahead of this. And that's the whole part of the initiative, being able to identify what are the kind of areas we need to start changing. And that's why I believe this grassroots innovation is really important. People are so busy practicing. If a CEO comes in and say, or Steve comes in and say, thou shalt do this, I'm not sure it's always well received, right? Even though it's the best of intentions. But having people really recognize that there's a win-win there is key. That's why providing them with incentive to say, like we did in health, healthcare practices in quality, safety, efficiency. Many people are organizing and creating care protocols, right? Continuation of care. Those things can really be effective in changing the practice of medicine.
Thank you, Dr. Dzau. Professor Mishkati.
Thank you very much, Dr. Dzau. Welcome to USC and thanks for a fascinating talk. As I mentioned to you earlier, my very specific interest in this area is patient safety. And in your slide 9, I vividly remember you had the no harm over there, and then you referred to the seminar report by IOM to err is human. Has there been any systematic vision or study, or how would you recommend that we look at the interaction and impact of decarbonization on patient safety? Because I have had this conversation with my students here and with colleagues at Patient Safety Movement Foundation, Dr. Ramsey and Dr. Masumi, about what will be the unintended consequence of decarbonization on patient safety. Because my fear is tyranny of a small decision. And the airbag example, that we go something very good, but then the unintended consequence of that on patient safety will be something that we may not like to see. Thank you.
Thank you, Namjin. Those are really excellent questions. And I'm aware that you serve on the board of the Joint Commission. And so these are essential questions when you start thinking about making these changes. I think, first of all, I would say I answer the question in the following way. I talk about patient safety as a lessons learned about how you can actually have a whole movement in going the right direction, right? When it was pointed out that patients are dying because of medical errors, and it's been a journey, but it's been a journey where you can now get into an operating room or go to a clinic or go do testing without someone checking your age, your band, your name and whole bit, and systematize a system approach to patient care delivery, in this case, patient safety. I think that can be done also in the area of sustainability. But what you're asking is a very important question, which really asks for more research, because as you said, what seems to make sense may have unintended consequences. So until you started implementing these changes, it's not because it makes logical sense because of this, therefore intervention that, but you have to do the research to demonstrate the benefits and possibly the damages and harms they can do. But that argues why we are learning health system, right? A learning health system, which we call in the word IOM, is a system that continue to evolve, to test, to learn, and to be better.
Right. Now we're entering the general question and answer session. I invite any of you who would like to pose a question to come to one of the microphones. We also received a question in the chat that I'm going to posed to Dr. Dzau. I think the question is, at some point you discussed some of the global implications of not only climate change, but also the necessity for a global response. And even though the healthcare industries in countries like China and India are probably responsible for much less of the carbon emissions, still the point is that the healthcare industry and healthcare professionals, as you pointed out, have a kind of a moral responsibility and can be a model for setting the standards on how we approach these kinds of issues. Is there any movement or any discussion with our colleagues in places like India and China to join this kind of movement and help lead it in their own countries?
Well, first of all, there's certainly increasing interest in this area. One can't say that healthcare is front end and central to COP26, 27, etc. But I think there's more recognition of the importance of this area, and that's really key. And in COP26, for example, I believe that maybe 80, 100 countries have all agreed to pledge in looking at healthcare role in terms of climate change, etc. So, and in fact, our country, HHS represented our country, talk about its commitment, certainly on behalf of Biden administration on this area for healthcare industry as well. Now, so I think that's one. Secondly, there's not a good, to my knowledge, systematic discussion among the healthcare deliverers of different countries on this area. The best effort is through the International Academic Partnership, or IAP, which have all the academies, science academies and medical academies of the world to start working on this area. But I think this is the opportunity, using whether that network or others, to look at what are the practices of mitigation and adaptation in the healthcare industry in different countries. Certainly, we want to know, as countries are becoming, say, more, for lack of a better word, modernized in the health approach, they now have a chance to look at, is this a practice we need to adopt or not? I mean, American exceptionalism always says, well, we know how to do this. We got this laser, we got this, we got that. And guess what? We are now, saving more lives. Maybe we should also look at your point, Jim, right? What does it mean to carbon emissions? So what's the net risk versus benefit? Do we need to practice this way or that way? Because we've never really asked that question in our country, right? Every new technology is a good technology. We don't even, maybe increasingly so, but even the cost issue, the equity issue needs to be totally considered. So maybe these are lessons learned that we can learn from our international colleagues.
One other thing I'll add is that the World Bank put out a document a few years ago, you might have seen it, where they made the point that as countries modernize their health systems, they have the opportunity to leapfrog some of the things that we've done and adopt sustainable practices. And some of the things that some countries have done actually are examples of reverse innovation, where things that they've done could be adopted by us.
Thank you for pointing that out, yes.
Let's go to the mic over here, Scott.
Well, thank you
Please,
for a
Scott.
very thought-provoking talk and comments. I'm very curious what you think the likely pushback will be from regulatory agencies, say the FDA, to bringing sustainability and full costing, considering the energy cost, into the scenario. It seems like right now the system is very much locking down some of the innovation that you're hoping to see.
Scott, that's a great question, and certainly I don't have a crystal ball except to see what we see. I do have a lot of confidence in my colleague Rob Califf, who will certainly be willing to push harder on more innovation, etc. But you're quite right. I mean, we certainly need simultaneous changes in the regulatory agencies, the funding agencies, and all this. Otherwise, it's not going to work. A very telling story or issue is that when I talk to the people in the private sector, they're quite eager to actually change their product and others but they found that to do so, the regulatory burdens are so high that it discourages them from doing this. So if they change any chemical in a product ingredient, they're gonna have to go through regulatory approval and prove that it's all gonna be everything, and it's just too high. So we need to say, change the regulatory burden to enable people to be more innovative to make those changes. So your point's well taken. Any thoughts from you?
And I forgot to ask you to identify yourself for the whole audience, please.
Oh, okay, sorry. I'm Scott Fraser. I'm very curious, having carried things through the FDA and seen the lockdown that takes place, and also watching recent vaccines, for example, that had energy inefficiency almost built into them, about ways that we might allow better mousetraps to be developed. That's something that it seems like we may need to be willing to fund as well as talk about.
Right. Scott, I'm actually also encouraged a little bit because after all, if you look at vaccine using emergency use authorization instead of standard approval faster. If you look at that monkeypox pending, I thought it was well done, right? Willing to split doses, being able to use small experimental data, right, rather than waiting. So I think we're learning, and we need to encourage and support them to be certainly more flexible. But after all, I mean, their job is to look at protection of patient safety. Right? And so they may set a very high bar for this.
Thank you.
Could I just bring up that you brought up the issue of patient safety being more than just the response to the drug. And your slide deck should be a high motivating sort of input to them about what the full costs are to patient safety.
Let's take the next question at the mic, then we'll switch to the Zoom, and then we'll come back to the mic.
Philip Lum.
Introduce yourself, please.
My name is Philip Lum. I'm in the Department of Anesthesiology. Please forgive me for being a little naive, but we are all individual practitioners, and ultimately, decarbonization is going to become not only a global effort, but an individual effort. And there have been no examples of a change being made that has a measurable impact. So, for example, I'm old enough to have practiced with glass syringes. We changed to plastic disposables. Was that wise in terms of the carbon footprint? And do we anticipate changing our current practices? We changed to just-in-time drug delivery ordering to decrease the storage capacity on our campuses, and yet we increase the number of trucks on the road that come to bring the supplies. There are certain things that we have in our armamentarium that we can measure very easily. So, for example, in anesthesia, we can measure vaporization of anesthetic agents by reducing the gas flow that we use in circuits. And we have the monitors to make that safe, so patient safety is not an issue there, but the footprint of the fluorides that we emit is significantly lower. Are there parts of the toolkit that your groups are providing that will allow us to measure a single impact and understand the collateral damage that that impact or that change may make, so that cumulatively individual practitioners and a healthcare organization like ours, how do we measure our carbon footprint today? And then in a PDCA cycle, we say we're going to decrease this particular process. Do we have the tools in our armamentarium to be able to measure the impact and determine whether it's positive or negative?
Phil, I think you ask a really, really important set of questions. Hardly can say you're naive. I think you've asked all the right questions. It does speak to the importance of getting evidence of what we do in order to proceed what we're doing. You know, so as I said earlier, you know, many decisions of our healthcare practices are based on what seems to be logical, but we fail to measure, you know, what the outcome is. But also importantly, there are certain things that we didn't realize before that we're now more aware, as we talked about in terms of carbon footprint. So obviously, it's important to go back. This again brings back the importance of research. If you don't ask those questions, you'll never know. If you ask them, you'll be able to get the at least appropriate information to kind of help guide your decision. The other point about practice, I certainly frequently worry about the influence of the commercial sector in the way we practice. Think about disposable. You talk about glass and plastic syringes and how do we get there, right? And sometimes it's for good reason. We don't want to, you know, I'm old enough to remember, you know, using glass syringes and needles which are sterilized, et cetera. And of course, it's much easier to get disposables, right? And the question really has to be now that we've done all this, is there evidence this is any better or not? And I'm also worried about the whole idea of consumerism that drives this kind of idea, right? You use your mask one time, you throw it out after surgery, you know, you wear your PPEs and the whole bit. So I think there's a lot of fundamental issues that we need to look at in order for us to be able to make the right decision. So you're spot on. I don't pretend we have the answers, but this is exactly what we need to do, is to activate the community of us, to ask those questions, do the research, and to get the right practice.
Thank you.
Thank you.
We'll be in touch with you about the toolkit. That's a great idea. Let me just go to the Zoom. Elizabeth Beal posed the question, the standard American diet, which has the acronym of SAD, by the way, is considered to contribute greatly to the climate crisis, chronic disease, and healthcare costs. Will addressing the SAD be part of the issues that NAM will tackle as part of this initiative?
I'm sorry, I didn't quite. Can you read it again?
So will addressing the standard American diet
Oh, yeah.
in terms of its contribution to the climate crisis, meat consumption, et cetera, and also chronic disease and healthcare costs, will that be something that'll be part of what NAM will address?
Well, we certainly have talked about this and maybe quote address it, but I think perhaps the roadmap that I talked about that Judy Roden and Edgar Hinz are leading would dive into greater detail on this. Certainly when we talk about 20 million premature deaths, some of that related exactly to your point about physical inactivity and diet, right? So not everything is bacterial or extreme weather. So this is a very big issue, meat consumption, et cetera. And of course, agriculture also plays in a big role. So the answer would be, yes, I think we'll get into those areas.
And we certainly have done that in our own cafeteria. All right, thank you. Let's go to the next question. Please identify yourself.
Thank you all for coming. My name is Aiden Nicewinder. I'm a undergraduate student in a few of Dr. Mashkati's classes, actually. And there's a concept that we spoke about in my class with him last year called safety culture. And it's a huge proponent of the healthcare industry. And I was wondering if you had sort of any concept or something similar, like a climate culture kind of, that you had thought to implement within a healthcare setting or elsewhere, and what that sort of looks like.
Yeah. Well, I keep coming back to the fact that we've been on a journey for 20 years in creating a culture movement in patient safety. There are lots of lessons learned along this. It'll be a missed opportunity not to learn from it, and then how to create a climate or sustainable culture along with it. I think they're convergent with the caveats being said that you've got to be sure that in fact they're not always, you know, they always go in the same direction. They're not, in fact, sometimes what you do counteracts each other. But I think the culture issue is really a attitude and mindset of the organizing individuals. So that we can learn what's good for patients in the issue of quality safety, we can learn what's good for patients in the area of climate and sustainability. I think it's the same mindset. Do you agree?
And as all of you know very well, it's being very much promoted by the Joint Commission. I'm a member of the board of the Joint Commission, but I'm not representing them, and I'm not speaking as a spokesperson for Joint Commission. And also for Patient Safety Movement Foundation, Dr. Philip Lum and myself also are on the board of governance. The issue of safety culture has, as you mentioned, has very big relevance to this context of decarbonization. And in fact, to the gentleman that was asked about regulatory agency, because Joint Commission is pseudo-regulatory, it has deemed status with the CMS. In support of Joint Commission, I have to say that Dr. Jonathan Perlin, that who is on Dr. Dzau's advisory panel, that you had his name over there, he has started a new initiative at Joint Commission on decarbonization. And it's one of his 3 strategic pillars. And as part of that strategic pillar, Joint Commission has started 2 sub-initiatives. One, they have convened and assembled and invited a technical advisory panel to, these are the national technical experts, to advise the Joint Commission how could they promote decarbonization in the healthcare industry. And the second thing which is related to Dr. Lum, by the way, Dr. Lum is a mentor of me here. Dr. Lum, Joint Commission is convening also an internal task force and a group to look at the standards, particularly infection control standards and use of disposable very specifically. And these 2 simultaneous movement is going on. This is one of the few occasions that I see a regulatory agency is becoming proactive. If you compare or contrast that with FAA and Boeing 737 debacle, I think Joint Commission is much more ahead of them. Thank you.
Any final words of wisdom, Dr. Dzau, as we close?
I'd love to hear from your panelists. I think we would love to talk to you. So I'm going to take the opportunity to comment on the question of our colleague in anesthesiology, and just point out that anesthesiology, it's the poster child for innovation in healthcare decarbonization, because the anesthetic gases are such potent greenhouse gases as well. And there's an emerging literature on efforts to reduce the impact of these. And we had one of your colleagues, Arash Motamed, came in and spoke to our working group, and he pointed out a very clever thing that had been done, I think in the Keck, maybe in the Keck OR, the perioperative services. He said, the biggest carbon footprint comes from desflurane, and the biggest benefit comes from discontinuing it. He said, well, he did something. He said, there's each anesthetic gas, as I'm sure you know, comes with its own cartridge. It's, you can't use the same cartridge for all the gases. So desflurane has its own cartridge, and he said you got to be careful with working with clinicians and with individuals. They got their way of doing things. He said, the department didn't forbid the use of desflurane, but he took out the canister, the cassette, whatever it is, and he took it to his office. He said, you can use desflurane. You got to come talk to me. And he said, I hope I haven't misquoted him. He said that tremendously reduced the use of desflurane in the operating service. And with the CEO for the hospital is here, apparently saves a lot of money as well to do that. So.
Bhavna?
Foreign to this audience, but we're seeing similar discussions talking about infrastructure. And on one of your sort of introductory slides, I noted that infrastructure was the basis for a lot of those medical outcomes that you discussed. And so infrastructure has a big role to play, and it's been really exciting to be part of this conversation.
Naj?
before and also in your presentation is the need for interdisciplinary research. And it's a music to my ear and my student. In fact, I'm here because of that issue, because of what I learned and what we did with Dr. Lum 12 years ago with Dr. Lum and Dr. Alex Capron, who's a professor of law and medicine. We started USC Health Systems Improvement Collaborative. And an engineer came with an anesthesiologist and a medical ethicist to work on that. I think the interdisciplinary research is the key in that. And thank you for highlighting that, sir.
On behalf of President Folt, Dr. Shapiro, and the President's Working Group on Sustainability, let me thank Dr. Dzau for his wonderful presentation in this event. Thank you all for coming. This session has been recorded and will be made available to your students.